Hello, everybody, and welcome to our Q&A session for our Pacific Western region part of the world, or US, North America. And today it is really an honor and a pleasure to be joined by Dr. Steve Rosen, which I know many of you know, may not require a lot of introduction, but I will just say he's the Provost and Chief Scientific Officer and Director of the Comprehensive Cancer Center and the Beckman Research Institute at the Irel and Manella Cancer Center Director's Distinguished Chair for City of Hope in Duarte, California, and has been a long time physician researcher in the realms of lymphomas and in T-cell lymphomas and cutaneous lymphomas. So welcome, Dr. Rosen.
Thank you, Susan.
And we are joined also today by Dr. Aaron Mangold, who is the Associate Professor of Dermatology at the Mayo Clinic in Scottsdale, Arizona, and expertise in cutaneous lymphoma and complex medical dermatology. So welcome, Dr. Mangold. It's great to have you with us as well.
Thank you.
And this is such an exciting opportunity to have kind of the best minds, right, on the hematology side, as well as on the dermatology side, which we all know cutaneous lymphoma is kind of the best of all those worlds, right, in a very complex environment. And I'll welcome everyone to put your Q&A, your questions in the Q&A box, and then I'll be able to see them on my handy dandy little dashboard here. And we'll just roll through the questions as best as we can for the hour that we have together. But I just thought I'd start off, hot topic as always for patients, and perhaps now with some of the new boosters coming out with regards to COVID. I think there's always questions around the cutaneous lymphoma community about, are we immunocompromised? How does that help? How do I deal with COVID? Should I be more concerned? Should I do the vaccines? And it's a tough question because we have a very broad brush of patients with varying types of disease. But I thought I might start and ask, since we have both of you here, and now we're 2 years into our COVID experience, what have you seen and in the cutaneous lymphoma patient population, and what kinds of thoughts and perhaps some insights that you can share with our folks. So Dr. Rosen, I'll toss it over and see if you've got a place to start.
I can start with some general comments, Susan, and then get to more specifics. So I think there's compelling data that individuals who are vaccinated in general have a milder course of the disease. It doesn't prevent you from actually getting COVID. I had COVID after being vaccinated and boosted, and it was relatively mild. I didn't require any intervention. I take care of patients with both B-cell lymphomas, which makes up the vast majority of lymphomas in the United States, about 80%, and patients with T-cell lymphomas. Patients with B-cell lymphomas tend to be immunocompromised in general. They often will not develop an antibody response to the vaccine, any vaccine. They may develop a T-cell response, and there's a lot of debate about the importance of the T-cell response versus the antibody response. But clearly they're at higher risk for severe infections. In that population, if they're infected, at the present time, we're treating them with outpatient Paxlovid, and if that doesn't work, we're using remdesivir. At City of Hope, we actually have a trial which has very strict eligibility criteria with a drug I've repurposed called leflutamide, which I've shown works as a therapeutic in myeloma, but it's the ideal drug for COVID because it's anti-inflammatory and antiviral, and it's generic and inexpensive and approved for autoimmune diseases. And everybody we've treated who have failed other treatments have benefited, but it's only on a trial. So for T-cell lymphoma patients, like patients with cutaneous T-cell lymphomas, the immune system appears to be more intact. I can tell you back in the 80s, we did a trial with mouse antibodies, mouse monoclonal antibodies as a therapeutic against a target that was both in B-cell lymphoma patients and in cutaneous T-cell lymphoma patients. And the patients with the B-cell lymphomas didn't respond to the mouse antibody. So they made no human anti-mouse antibody response, whereas every T-cell lymphoma patient developed a whopping anti-mouse antibody response. And so my suspicion, though I haven't seen enough data yet, is that the vast majority of patients with cutaneous T-cell lymphomas will respond to vaccines. In the B-cell lymphoma patients, we are using Evusheld, a passive antibody, as a protective vehicle. And it's given every 6 months now because of its half-life. And I've had several patients who everybody in the family was infected, but their infection was much milder because they had Evusheld. In general, we've not been giving it to our T-cell lymphoma patients at the present time.
Dr. Mangold, anything to share based on your experience over the last 2 years? And I'm sure you've gotten a lot of questions as well from patients.
I think where I will start is kind of on the other end, which is recommendations for most patients, especially early stage patients, is clearly to be vaccinated. I think one of the things we see most commonly in our practice is exacerbation of skin disease with vaccination. And that's something that's involved a lot of coaching with patients, where we've seen individuals with Sézary who have transient skin flare that is self-resolving. We've seen other cases of people who have tumors that will transiently flare when they get vaccine. And this has been described in other cancers as well. So one of the things from our standpoint is, yes, we recommend vaccinations, especially in the less immunocompromised, with no concerns of, are they going to mount a response? But really the focus being of, if you get a skin flare, if you notice your tumors transiently enlarge, we see that. It's normal and it will resolve. We haven't seen in our practice any patients who've actually had true disease progression with vaccine. It's typically that immune stimulation, which then stimulates the normal and malignant cells, which then sort of self-resolve over time. I would say that's probably been the two most common questions. Number one, should I get vaccinated? Number two, is my skin going to flare during that time frame? I completely agree with Dr. Rosen as well. This is a subset of people with respect to immune response to vaccine that we think should get a protective advantage and should hopefully have milder disease when they're vaccinated.
Great, that's good to know. And then I think that's the first time I've heard, that there might be a possible skin flare. So good to be aware of that in case that happens and you get the vaccine, not to panic, but also to make sure that folks are seeing their physicians so you can just monitor, because as we know, it's challenging, right? Yeah.
One, and I think a great example too that comes up, I can think of one case that we reported, I believe, which was the first case of new onset of prior complete responsive disease after vaccine. We've seen patients where they've developed like a CD30 LPD that recurs after vaccination hadn't been present for a long time. Interestingly, in those cases, I was saying it tends to be self-resolving. It's just a transient immune stimulation, number one. And number two, it often doesn't correlate with next dose. So a common question that will come up is, my skin flared up, should I get my booster shot? Our point of view has been yes. And we have a large series of patients where they've had some side effects with one shot, but not with another. And it doesn't correlate one-to-one.
Interesting. Very interesting. And I know, prior to coming on board, Dr. Rosen and I were chatting a little bit about the clinical community globally are beginning to collect the data experience across all of the institutions that see cutaneous lymphoma patients and the experience with COVID. So we're looking forward to seeing some of that data that comes out of that perhaps soon. I don't know when all that's going to be together and be shared, but just to let all the patients know that the clinical community is actually very engaged in capturing the data specific to cutaneous lymphoma and COVID. So I suspect we'll see some interesting data coming out of that can be shared and then put into practice as we go forward and try to navigate whatever's coming next. Who knows, right? Who knows what's coming down the pike? So let's see, where shall we start? So maybe we start a little bit by talking about maybe a tangent on this discussion, not necessarily about COVID, but we do get questions with regards to people's immune system, right? And with cutaneous lymphoma and all the different variants, there's a broad spectrum. What would your perspective be with regards to someone's innate immune system, if you will, based on their disease state and their compromised immune system in general, and how does that correlate maybe to disease progression? Dr. Rosen, any thoughts?
In general, the immune state is pretty healthy, definitely in comparison to B-cell lymphoma patients. And if it's affected, it may be affected by an intervention, though the majority of the interventions for cutaneous T-cell lymphomas don't truly compromise the immune state. One therapy which we don't use as frequently as we did in the past was alemtuzumab, an antibody that was often used for Sézary patients, but now replaced with mogamulizumab. And so I'm trying to remember the last patient I took care of who had a bizarre infection, in contrast to my B-cell lymphoma patients, where it's quite common. It's just, it's not at the same risk level.
Got it. Dr. Mangold, any thoughts?
Yeah, I think there's a couple of things. I agree with regards to general immune function being relatively normal. I think some of the things we do know, though, about cutaneous lymphomas is the skin barrier, as well as some of the functioning T cells within the skin do have some gaps in them. For example, we know individuals with folliculotropic MF that tends to be more progressive and relapse refractory. Then I know the Northwestern group has published extensively on this, that they tend to harbor certain species of Staph aureus. Recurrent infections are associated actually with poor outcomes in those individuals, not just with respect to sepsis or infection, but also with respect to disease progression, probably reflecting some of that imbalance within the immune system. Another thing I think that you notice in early stage disease with progression is really just the normal repertoire of immune cells that live in the skin. And as the disease progresses, you see, I always tell my patients, I think of it kind of like a forest where all those little T cell receptors are like trees, and you see the forest kind of being cut down. And then there's one big tree that's left over. And that is associated, often with disease progression, whereas when that forest is able to repopulate and grow around that large tree, you see improvement of disease. So we do know that with respect to the normal immune cells, having them around, number one, is good for a lot of reasons, but it also probably balances some of that tumor microenvironment to keep the disease in check. And when you translate that, I think, into clinical practice, most CTCL or cutaneous lymphoma centers will focus therapies that don't reduce immune cells, or not cytoreductive. We'll focus with therapies that are immunostimulatory in some scenarios, depending upon if it's systemic or skin directed, as well as we'll use targeted biologics, as Dr. Rosen had alluded to, the replacement of Campath or being mogamulizumab, which is very well tolerated, is actually immunostimulatory in many ways and seems to do better in the long run. Or if you go back a long time ago, using drugs like interferon, which is unfortunately fall by the wayside because of availability, those drugs are extremely effective and keep people immunocompetent. Complications-wise, I think it's very relevant. I know with my Sézaric patients, barrier is important, keeping the skin clean, keeping it protected, and really avoiding the thing that seems to cause issue, which is unfortunately sepsis from Staph aureus infections or the things that colonize the skin.
Right. Yeah. Okay, I'm going to try to summarize this question and see if I can get to the gist of the question. So it looks like they haven't had a definitive diagnosis for CTCL from the biopsies over 2 years of having symptoms. Not sure I quite understand. They had some, it looks like maybe 14 years ago, an original diagnosis, but recently they had more patches that showed up on their back. They've been doing phototherapy, looked like MF stage 1, took some weeks off, and now they're doing just kind of clobetasol, and they're getting a home light box unit so they can do the light therapy at home. But now the old patches are receding and some new patches are showing up, and it looks like they might be moving to add a systemic agent like methotrexate in a low dose. Just trying to understand, they're trying to understand kind of, I guess, where they fit within the treatment landscape, right? With disease that seemed to be under control, but now is flaring, and light seems to work, but they're kind of in between access to light. So any thoughts on maybe how you navigate these times when you might be either in between treatments, or you're stable for a long time and then your disease flares and you kind of go, well, now what's next? And should I go to a systemic therapy, or should I just stick with the topical? And I know that's probably very specific for this patient, right? You can't know exactly how to respond, but I think a lot of times people struggle with that kind of question, when should I add a systemic agent? Should I stick with what seemed to be working? So any thoughts or comments or insights that you all might share? I'll let either of you take a stab.
I can stab first, since it's probably earlier stage, more in the derm
Okay.
realm. One of the things I think with mycosis fungoides, especially early stage disease, and I tell patients this all the time, I think it was Roger Bannister said the problem with people when they run is they run too fast when they want to run slow, and run too slow when they want to run fast. You have to know the response rates with therapies and the long-term trajectory of disease, and then decide what is the appropriate therapy. There are individuals who have early stage disease that we've put on romidepsin before, and there are reasons why we did that was because of the patient specific issues. And there are other patients who have very similar disease that we don't put on any therapy at all, right? And I think you have to take those things into account of what is the goal of care. In stage 1A disease, the goal of care is not prolonging someone's life because they're going to live like everybody else. It's to minimize morbidities associated with the disease, or to really allow that person to live their life to the fullest. And just had this discussion on Friday in my lymphoma clinic with an 81-year-old gentleman who had quite extensive disease, and really he didn't want to do any therapies, right? So you have to have that intimate discussion, and you have to come up with really what is the goal we're looking at. Are we going to cure you? Probably not, but we want you to live like everybody else. So as I jokingly will say, you have a t-shirt that says I have mycosis fungoides, and that's the extent. It's not defining you, but it's a part of you. As the disease with skin only progresses, there are maybe some mortality associated, but again, I think the focus is on reducing morbidity. The most difficult patients I find to manage are individuals who have early stage disease that is either highly symptomatic or highly refractory to therapy. And those are difficult discussions because you go from relatively low morbidity therapies as well as low financial toxicity to higher morbidity therapy, some even with mortality associated with rare complications and extremely high cost. So there's not one size fits all, and there's not one therapy that stays on you forever. We often rotate therapies, and we'll switch through. But I think the big deciding point in do you go to systemics is your disease defining that you need to make that transition, or are there symptoms for you that are defining the need to make that transition, be it bexarotene or targretin or methotrexate or interferon? I don't think that there's a right choice. There's a lot of different flavors. The one thing I will tell patients with earlier stage disease is typically the wrong choice is chemotherapy at the beginning. We do know that from data from a long time ago that we shouldn't do that, but there's a lot of flavors and degrees of, this is the right thing for me. At the same time, though, I would ensure that, again, that cadence, don't go on methotrexate or don't go on Targretin and expect tomorrow for things to clear up. These are diseases that are chronic, and the treatments have, often slow, sustainable onset, and often will give, durable benefit in those scenarios.
Right. Dr. Rosen, anything to add?
No, I agree everything that Aaron said. If you look at the guidelines from the National Comprehensive Cancer Network for each stage, and whether it's initial treatment or subsequent treatment, there are a dozen options, and you go to different institutions and you'll get different opinions. Clearly, it always has to be individualized. Aaron alluded to a trial that I was involved with as a fellow at the National Cancer Institute decades ago, where patients were randomized to sequential, essentially palliative treatment. They started with topical nitramustid, then they got PUVA, then they got single agent methotrexate, et cetera, versus, and this was a randomization, very aggressive multi-agent chemotherapy and a total electron beam skin irradiation. And I think, to the surprise of the investigative group at the National Cancer Institute, the prognosis was no better with the very aggressive treatment than with the sequential palliative treatments. And in fact, in patients with the most advanced disease, they did more poorly with the very aggressive treatments. And I was very proud of the fact that I was one of the first people to stop using chemotherapy in skin lymphomas, and then in myeloma, and then most recently in chronic lymphocytic leukemia, where we no longer use chemotherapy for any of those blood cancers. And we've gotten into the use of biologic approaches.
Yeah. Yeah. A new wave in the future, which I think is very exciting for all of us in all different diseases. So again, I'll try to condense this question. Hopefully I get it right. And please feel free to tell me if I get it wrong and we need to recalibrate. So she was diagnosed 1A MF 10 years ago, probably had it for a long time, underwent skin-directed therapy. And then a few years ago, she noticed clustered papules in a different area, had a skin biopsy to rule out LYP. The path report says suggestive of recurrent MF, increased number of CD30 positive lymphocytes. And she's wondering, how do you get, can she get a clear diagnosis to confirm whether these new papules are MF or LYP? And I know we have quite a few patients that have both, right? And a little different iteration on a similar theme. Maybe you can speak to, what's the best way of trying to get a good diagnosis, so you know what you're treating and what you're dealing with, whether it's all MF or MF and LYP at the same time, and how do you, what's the best methodology to try to navigate that so she knows how to make good decisions for treatments with her physician? Any thoughts?
I can take a first shot. So one of the things to keep in mind, and I say this working at a referral center for cutaneous lymphomas, you can have the best dermatopathologist on planet Earth, or even a team of them, review pathology, and there are limitations. Cutaneous lymphomas are one of the diseases where it's clinical pathological correlation. And you really need to look at the biopsy, and you need to look at the patient, and you need to look at the biopsy, and you need to look at the patient, and look at the course over time to make the decision. There are cases that we see in other diseases like CD4 positive small medium T cell lymphoproliferative disorder, where you literally can't tell. And the reason you can't tell is you have to see the patient. If someone comes in with papules that are CD30 positive, look a little like MF, look a little like lymphomatoid papulosis, and they're self-regressing, well, it's lymphomatoid papulosis. if you see that same biopsy report and you see the patient and the biopsy came from large, annular circinate plaques all over the body, well, that's not lymphomatoid papulosis. That's probably a CD30 positive MF. Or you see that same person and that individual has something the size of a softball that's been growing on their shoulder. They have primary cutaneous anaplastic large cell lymphoma or a skin manifestation of a systemic anaplastic large cell lymphoma. But those could look very, very similar under the microscope. I think one of the hard things as clinicians and one of the hard things as patients in 2022 is we don't like the answer of I'm not quite sure yet. And it's much easier to assign a diagnosis than to not assign one. In those cases, I think what you have to do is to say, this is what I see. Let's watch the disease course, and then we'll decide what do we want to call this and does that impact treatment. The good thing I would say is if you have MF versus CD30 positive MF versus lymphomatoid papulosis with MF, there's not a large difference in treatment approach, and a lot of the therapies do overlap. But I think from the point of view of patients, you feel like, how can I have two rare diseases? Suffice to say, I think you had alluded to, Susan, it's not that uncommon to see these co-occurring together.
Right. Dr. Rosen, any thoughts?
So I agree with Aaron. I'll just tell you a few stories. So years ago, I saw a gentleman who had generalized skin lesions. A biopsy was described as large cell lymphoma. He had lymphomatoid papulosis. He had gone to Loyola where they recommended that he have chemotherapy and a transplant. He went to University of Chicago. They wanted to put him on an experimental regimen. And then he came to us and we said, are you symptomatic? He said, no. I said, does the cosmetics bother you? No. I said, let's just watch. And he almost fell out of his chair. He died in his 90s from unrelated causes. Maybe 20 years ago, it was a summer, and a young boy came to see me with a lesion on his forehead the size of an egg. And it was a CD30 positive lymphoproliferative process. And we were debating, honestly, at the time, whether we were going to treat him with radiation alone or radiation and chemotherapy, because it's just as we were transitioning to not use chemotherapy at all. And there was a world's expert on lymphomatoid papulosis, Marshall Caden, who was out of Harvard. And we sent the slides to Marshall for review. Fortunately, Marshall was on vacation, because in the 3 weeks from when we sent the slides to Marshall getting back, this egg-sized lesion completely regressed. And when Marshall got back, he told us this was definitely anaplastic large cell lymphoma of the skin. Shows you how challenging it is. And then subsequently, we saw two other students. This happened to be a student from the University of Wisconsin who had similar lesions on the face. It probably was mosquito bites that looked like CD30 positive lymphoproliferative disorders. So it's a fascinating area. It's a fascinating biology, and you definitely don't want to do any harm. Christian Querfeld, who's the head of our cutaneous lymphoma program, also like Aaron, a dermatologist, and she's a dermatopathologist. We just saw a gentleman in his 80s, I think it was 2 or 3 weeks ago, who was told by his, in this case, dermatologist, that the biopsy showed large cell lymphoma. We need to start aggressive therapy. And in conversation, he had lesions waxing and waning over a number of years. And he had an interesting variant of lymphomatoid papulosis. And again, we told him, unless this bothers you, we would not intervene. So.
Yeah, thank you. I think that's a really good question or comment or thought. You know, it gets challenging from a patient perspective when you don't know what to ask for or kind of when to push back, or, you know,
that's when they should contact you, and you should say, these are the experts who should take a look and
right.
help.
Yes, go get a second opinion, right? That's the key, right? But I think that's an important thing, and in such a complex disease where it's challenging, and you have to be an experienced practitioner to be able to, especially in the nuanced diseases that are not, I mean, it's not clear cut to begin with, and then you throw a few more monkey wrenches into the mix, it becomes even more challenging. And I think the do no harm first is the key, right? Yeah. So let's see. So our first question that we had with the woman that had the patches on her back, I actually misinterpreted her question. She said, she clarified for me. They thought she had, I think, another kind of lymphoma 14 years ago, and then tested 11 years ago, and it came and went until 2 years ago. And since then it's been active and hasn't receded to a dormant stage. So I guess that's, a question with regards to disease course sometimes, particularly for mycosis fungoides. Have you ever seen patients where it's quiet and then flares, and then is quiet and then flares, and how is, or maybe what's the best approach maybe to treating and grappling with that over the course of time, when you don't want to your point, over treat, do too much treatment, right? When sometimes you just want to take it a little bit slower. Do you have any thoughts or ideas for patients in how to kind of navigate that kind of challenge? Treat, don't treat, what should I treat with? Should I go aggressive? Should I not? How do I grapple with that? Or how do I talk to my physicians about what's the right approach?
I think there's kind of a few embedded questions there. One is, do you see disease that has a non-specific phase that waxes and wanes before it declares itself? And yes, we do. I mean, I would say the data that we've published on pretty extensively is Sézary syndrome as an example, where patients often go through a pre-Césaric state for sometimes over a half a decade before they really get the true onset of symptoms. And it's how these immune cells evolve over time in that environment and what your normal immune system is doing against them. So that sort of waxing and waning we do see before there's a more definitive diagnosis. I think one of the hard things for patients, and I'd be interested to hear Dr. Rosen's opinion about this, we don't have data in cutaneous lymphomas that our therapies, when we set the highest bar of what does a drug do, does it prolong someone's life? We have a lot of data, and we have better endpoints on trials that say, how does this drug work over time, and in what compartments does it work? But we don't have that data. We do know from other indolent systemic lymphomas that whether we treat you at time of diagnosis versus whether we wait till the disease decides it wants to be treated and we give similar regimens, we know those patients do almost equal, for lack thereof of better term. And I think it's hard because, again, we're a society of doers and diagnosers, to really take that idea and say, well, if you would have diagnosed me 5 years ago, I would live 5 years longer, or my disease, I wouldn't have tumors. We don't have that data yet. And one of the biggest limitations is this is a chronic disease that tends to be indolent, and our staging systems are severely lacking. The common stagings we use don't as accurately predict prognosis as we might like, and it makes it exquisitely difficult to say, are we doing better? Are we making you live longer? Are we helping you? And as Dr. Rosen also alluded to, we only really have one trial that showed that maybe don't do this because it might shorten your life if you have advanced disease, but the rest of it is a big question mark. So I think for patients, the hardest thing to grapple with is whether I do phototherapy or whether I do methotrexate or whether I just jump to a really strong systemic therapy that might get me a good response. We in all likelihood have no idea if we're making you live longer. We might make you look a little bit better for a period of time, but it's that shift again of, are you managing morbidity, or are we really concerned about outcome? Until we get to advanced disease, the short answer is probably not. And I think it's hard as patients to see that, where I'm not quite sure what it is. And if I made that decision earlier and we called it MF, am I going to live longer, do better because of it?
Right.
I agree completely. I really don't have anything to add there.
Good. Yeah, it's a challenge, right? So here's an interesting question, and I think this is a really good one. What does the CD4 CD8 ratio tell us? So I know that, when folks get their results and we talk about these markers or these ratios, like what does that mean? And how do I interpret that? And then how does that help determine potential therapies or where I land in the landscape of the disease? Dr. Rosen, want to take a first pass?
The cutaneous T-cell lymphomas in general are CD4 positive, and so you see typically an amplification of the number of cells that are CD4 positive in the skin or in the peripheral blood. Whether it's mycosis fungoides with blood involvement or the Sézary syndrome, there are some cutoff figures we use, and also the clinical presentation of total body erythroderma versus patch plaques, etc. I can tell you an interesting story around CD4 since you brought it up, because I don't know how often it really dictates how we use treatments outside of it's supportive of mycosis fungoides. But when I was a fellow, the first patient I saw had very aggressive disease, and different than any other patient who was on the unit at the National Cancer Institute at the time. And it turned out that he actually had a brain lesion. He had a lytic bone lesion that actually went to an amputation. He had a very large spleen and liver and circulating cells that were hyperconvoluted, but didn't quite look like the Sézary cells, but more popcorn-like. And it turned out he was the index case for what's now known as HTLV1 lymphoma, or the adult lymphoma, T-cell lymphoma, that is endemic to certain portions of the world, Africa, the Caribbean, South America, and interestingly enough, Kyushu, Japan, because the Portuguese used Kyushu as a staging area for slaves from Africa, and that's how it entered Kyushu. So a number of things came together that led to the discovery. One of which was the technology to make monoclonal antibodies, and that was in 1975 by Kohler and Milstein. And so we were making antibodies against cancers and every subset of normal cells. And one of the antibodies that was made was OKT4. And we call it now anti-CD4, but it recognized the CD4 cell population. And so here, this individual had OKT4 cells in abundance. In Bob Gallo's leg, Frank Richetti had discovered what was called T-cell growth factor. We now call it interleukin-2. Turned out that this individual cells were producing a great deal of interleukin-2, and in fact, his cells were one of the few cell lines that we used to study the disease. It was human T-cell lymphoma, cell line 102. There was only one other that was started out of the first 101. So it shows you how difficult it was to grow these cells outside of the body, and you really need the microenvironment to sustain the growth of these cells. Temin in Baltimore, who won the Nobel Prize, had discovered reverse transcriptase. So this was an RNA virus that has some relevance to COVID. COVID's an RNA virus, and that's why it's so difficult to make vaccines against RNA viruses. They keep mutating. And the electron microscope had been advanced that you could actually see viral particles. And this work was done by Bernie Poise. And so they started a cell line from him, and they isolated the virus. The original report was the CR virus based on his initials. Turned out that his wife had antibodies against the virus, as did a patient from Boston. And you say, well, and who's Caucasian? How did that happen? Well, it turned out he spent 2 years in Kyushu as part of the Merchant Marines and would go to the bordello. So that was the connection. I got tuberculosis from him. So he had rare, he was immunocompromised in contrast to most of our mycosis fungoides patients. So you think, what was happening in 1979? Young men in San Francisco were developing bizarre infections, also affecting OKT4 cells or CD4 cells. And so it was assumed that HIV would be a similar virus, and it was originally called HTLV3 because that was the presumption. Turned out it wasn't a similar virus. But that was sort of the origin of discovering these CD4 cells, which are helper cells, but they're the cells that are involved in general for the cutaneous T-cell lymphomas. And it helped us with the diagnosis more than anything.
Mhm. Dr. Mangold, any thoughts on, what do we do with this CD4 CD8 ratio, and is it something that we use to monitor disease, or how does it play a role perhaps over time? Is this something we should be looking at if it changes or increases?
I think from the simplest standpoint, especially now, I think patients have access. I know our patients, as example, have access to everything. So you can read your pathology report and say, what did they mean when they said this, that, or the other thing? And one of the things you'll see are those ratios. As first pass, they're used really to define the immune cell infiltrate and identify if that infiltrate is aberrant or not, right? You should again see similar numbers and similar types of cells if there is inflammation. And the further they get from these similar balances, you say, well, that's not quite normal. Now, when you look at why might that not be normal, there's one possibility that there's too many CD4 cells, and those could be CD4 positive cells that are malignant or lymphoproliferative disorders or reactive. The other possibility is that there's not enough CD8 cells. And those ratios can be important, although not used in common practice. For example, when you look in the blood, we do know patients who have Sézary syndrome, who have very, very low CD8 counts, they don't seem to do as well. And do we do something to target those CD8 cells, or do we necessarily treat them differently? No, but in my practice, for example, I do quantitate the cells at baseline to say, what does your immune system look like? Do you only have Sézaric cells in your blood, or do you have other immune cells that are functional? And again, we do see some prognostic value of CD8 cytopenias in patients with these more aggressive lymphomas might not do as well. From a targeting standpoint, I don't think it's necessarily that relevant. It can be relevant, though, in the lesser common CD8 positive cutaneous lymphomas. And then there it can be extremely important because there are variants of mycosis fungoides, for example, that's CD8 positive, that is extremely indolent. Some people have even argued, do you call that mycosis fungoides or do you call it a lymphoproliferative disorder? And what's the difference? But there are other cytotoxic lymphomas that can happen in the skin that are extremely aggressive, extremely aggressive. And the differentiation there kind of goes back to the lymphomatoid papulosis versus CD30 positive MF. It's typically clinical pathological correlation. And we do use some of those to raise question marks. For example, I can provide a general case of an individual who is said to have CD8 positive MF, talk to the patient, and they had patches that were hypopigmented present for a decade and a half doing nothing. Very similar pathology of another outside referral that we ended up seeing, who had things that looked kind of like MF that were eroded, had positive cytotoxic markers, and was a cytotoxic lymphoma, which is extremely aggressive. And we do use that to raise the suspicion to say, could this be an actual cytotoxic lymphoma? Could this be a different type of lymphoma altogether? Gamma delta lymphoma is another very rare one that can do this. It can be aggressive. I think as the practitioners, it's useful for us to say, do we raise any red flags? From a patient standpoint, I think it maybe adds some confusion because I don't think that necessarily those things are prognostically relevant as much as we would say in mainstream. And someone might ask the same question to say, well, I've got a T cell clone in my skin and my CD4 to CD8 positive ratio is normal. Does that mean I don't have MF, right? And you could in the right clinical setting.
Good. So then that brings me to the next question about what is that diagnostic group of procedures that should be done upon to make a diagnosis? And then what are the kinds of, are there things that should be periodically tested to monitor the disease? I'm guessing it probably depends on the variant and so forth, but in general, at the time of a potential diagnosis, what's the general panel of testing that you all do, or you do for a patient to come up with the diagnosis? And then once you have a diagnosis, what are those tests that maybe you should do periodically, or how do you monitor where the disease is and how treatments are working, or is the disease progressing and so forth? Any thoughts or recommendations?
I can go with early stage disease first. I think the diagnostic criteria, when you look at them, there's nothing that's set in stone. Even the consensus of early diagnostic features of MF, there is still some gray area, but in general, you should have spots that are, typical in morphology to looking like MF, that are persistent and maybe progressive over time. And on histopathology, when you biopsy those areas, in general, you should see, as we talked about, that difference of CD4 to CD8 ratio. You may see certain other markers like CD7, CD26, which may drop out, just again, indicators of aberrancy. And you may or may not see clonality depending upon how you look at the tissue. I think, at least in my practice, when I see patients and they don't meet all of those, I often give them a diagnosis of atypical lymphocytic infiltrate, and then I give a differential of what it could be. From the definitive diagnosis, in those cases that really fit well, again, using mycosis fungoides as example, I'm not an over-tester in my practice. I think dermatologists in general may be a little bit more apt to rebiopsy. I really look at, in the disease, is doing an additional test going to change my course of management? And unless the disease is progressive, non-responsive to treatments, or there are other signs or symptoms to, warrant further workup, I don't often repeat many labs. I often don't repeat biopsies because it's not going to affect my next course of treatment. When I do think I may need to change treatments from, say, skin-directed therapies to selected systemics, I will often evaluate those patients, because we do know now with systemic agents that the response rates, again, by what sort of general bucket is the disease in. Is it a skin disease? Is it a lymph node disease? Is it a blood disease? Is it a little bit of all of them? We do see deviation in how these treatments work. And I think the newest example and the best example that we have is mogamulizumab, which is, as I tell patients, this is the Ferrari in the blood. I mean, this drug is unbelievably effective for blood disease. But if you have a patient who has bulky nodal disease, it's probably not going to debulk their lymph nodes. So I tend not to do a lot of repeated testing. Again, if we want to assess response, we will. For assessing response in the blood or lymph nodes, we'll do reassessments, but usually it's diagnosis, treatment, and then clinical follow-up to dictate what do we do next, meaning do we do biopsies, do we do labs, et cetera.
Yeah, I would agree. It's mainly a physical exam and a skin biopsy. We reported decades ago that CAT scans in patients who had no evidence of adenopathy by physical exam were pretty worthless. And ironically, we would often pick up other disease processes, but not anything related to cutaneous T-cell lymphomas.
Interesting. And I think that sometimes gets challenging for patients as well, because we're all taught, right? Go get all your preventative diagnostics every year and so forth. And it's like, well, I have this ongoing chronic disease. How do I know? But the good news is it's in the skin, right? You can see it. So as a patient, if you're living with it, I always think it's a good idea. We know our skin best because we're looking at it every day, and we have a pretty good idea of some things changing to bring that forward and to have the conversation about that.
You had asked earlier on about disease where you don't see anything, and how does it? It was interesting when we did some of the original trials with ultraviolet light. It was surprising to us. We would see disease manifest as the initial light therapy was being applied in areas that we didn't think was involved, so.
Yeah, and we get that question a lot actually at the foundation, and it may be, Dr. Mangold, you can speak to this a little bit. All of a sudden someone gets a diagnosis and, okay, great, I'm doing UVB light therapy, and now my disease looks like it got worse. What happened?
Yeah, it's a very common thing. Phototherapy, I think it comes up some. The one that it comes up the most is when we do low dose total scan electron beam. patient's disease comes up really quickly that they never saw. The reason that happens is there's reactions in the local tissues, even with that quote unquote invisible disease, that are your normal immune cells reacting against the malignant cells, and then the response within the keratinocytes to all that inflammation that occurs. So it's not uncommon that we see transient flaring of skin. I think one of the other ones too that we're very aware of from other diseases, and even a phase 1 trial that we're running now, some systemic therapies too can have a pseudo progression. I think the one that everyone should be aware of who practices are the mogamulizumab associated rashes. Those are ones that are very common, and I would still say now we get quite a few referrals of question of progressive disease when patients are receiving mogamulizumab, but that sort of awareness that with immunological cancers, things that stimulate immune cells will cause immunological responses, and they may be more than expected because of the type of cancer it is.
Yeah, we had reported that with lenalidomide a number of years ago, which will also show flares in other blood cancers, and then you see a regression.
So how do you manage that from a patient perspective? Because you probably don't know who might have that reaction, one person versus another. So there's no predictive component, right? To at least the best of my knowledge. So how do you counsel a person? And then how do you know, or how should the patient know, like, should I be overly concerned about this, or should I not be too concerned? Like, this could be a normal, like, how do you navigate through that? Or how do
Hopefully
you
the
counsel?
physician who's providing the care, there would be a dialogue about what's going on. But you see it. I'll tell you one other interesting observation we had years ago. Aaron had mentioned interferon, and there's a wonderful story with interferon. So when interferon first became available, it was clear that it had unique activity. And in fact, in one review of all the systemic therapies, it's probably still the most effective for traditional mycosis fungoides. And that was a patient of mine. We had started trials with interferon in Chicago, who actually went to Arizona in the winter for 10 days because of a loved one's funeral. And when he came back, all the areas that were sun exposed, he wore a V-neck t-shirt, et cetera, the disease melted away. And so we started the original trials with PUVA and interferon. And today, I think it's still the most effective therapy that I've ever been engaged with. It's not used as frequently for a variety of reasons, but it's incredibly effective. But what was fascinating is the alpha interferon that was being used. About 20% of patients with cutaneous T-cell lymphomas with repetitive injections of alpha interferon would develop neutralizing antibodies. And we would often see it in effects on blood counts initially, but we would then document the neutralizing antibodies. When we combined it with PUVA, you didn't have any neutralizing antibodies. And we published on this, again, several decades ago. And now what I presume was happening, because back then we couldn't document it, was that the light therapy was damaging antigen-presenting cells in the skin, the dendritic cells. And so you weren't getting the presentation of the antigen to the immune system and a subsequent antibody response against the interferon, which would abrogate the effect. Its patients would progress when they developed antibodies. So the combination was beneficial in several ways.
Interesting. Well, as someone who did a lot of interferon over the course of probably a 20-year window, and I'm here to talk about it, probably had a positive impact. And yeah, challenging. Anyway, that's a whole nother topic of conversation on availability and when things go off patent or go away and all that good stuff. That's a whole nother conversation for another day. So we have about 5. Okay, here we go. Let's see. We have about 5 minutes. So we have a question. Can you speak to the risk of secondary cancers and if that gives any indication of disease progression? So is there any correlation between, a cutaneous lymphoma diagnosis and having another cancer? And I guess there's probably a variety of ways to answer that depending, but Any thoughts?
I think in general, it's mainly skin cancers from the light therapy that patients are exposed to at times. Systemic, I don't know of any data suggesting a significant increase in systemic cancers in patients with cutaneous T-cell lymphomas, in contrast to patients with B-cell lymphomas, where there is a slight increase.
Interesting. Dr. Mangold, anything to add?
No, I agree. There are, I think, on the far end of the spectrum, the average person on one end with mycosis fungoides, again, this example, do they get other things? Sure, usually they're indolent. I mean, as we talked about, lymphomatoid papulosis and MF are very common to co-occur. I think on the opposite end, when you think about, are there genetic predispositions to getting things like lymphomas and other cancers, there is some data on that, but it's something that I think is at such an uncommon level. It isn't when someone walks through the door, if they get breast cancer, we do BRCA screening, right? When patients walk through the door with MF, we don't recommend, inherited cancer screenings that may detect something else. And melanoma, the other one is, pancreatic cancer with genetic predisposition. We don't have data like that. And again, I think it's not as exciting or as sexy per se as a whole body PET scan, but a conversation of how are you doing in a physical exam goes a long way with most patients with skin lymphoma, and taking into account how they're feeling, how they look, rather than something like genetic testing to say, do you have some other predisposition?
One interesting observation we had, again, decades ago, we looked at HLA associations, because here you're looking at immunologic cells. And we were able to show that Sézary patients had an HLA phenotype that often resemble patients with autoimmune diseases, which is not surprising. We didn't see that in the classic mycosis fungoides. And subsequently, it's been shown in some of the indolent B-cell lymphomas, also the HLA association may be the most important and not a specific genetic mutation.
Interesting. I think that's also frustrating for patients, with the general news that comes out about, the genetic connection or a gene, a specific gene for a specific causing, or a lack of a gene, or a morphology of a gene that causes a cancer. Like, there's not really any rhyme or reason that we are aware of, and it's not a genetic disease, not a genetic cause. So it's kind of like, well, where did it come from and why did I get it? I won that lottery. But I know there's a lot of research going on and trying to understand that, how the disease manifests, how it functions, how it becomes, it gets smart and it avoids the treatments and all those kinds of good things. So we've got, this is my 2-minute warning. So I'll give you each a minute to just share any area of interest that you might see maybe on the horizon for hope for new therapies or new approaches to treating and managing cutaneous lymphomas. I know that's a minute's not a long enough time, but.
Dr. Rosen, do you want to start?
Sure. So I can tell you what we're doing at City of Hope. We have a number of grants from the Leukemia Lymphoma Society and from the National Cancer Institute focused on the microenvironment, which is very relevant. I mentioned you can't grow these cells outside the body. And so we know that there are cells in the body that are fostering their growth. And one of the trials we have right now that's supported by the National Cancer Institute, and we're doing correlative studies, is looking at antibodies against immune regulatory proteins. And this happens to be one called PD-L1 plus minus immunostimulatory drug called lenalidomide. And we've had some home run responses with the combination. A few patients out over 2 years now with disease control. In my lab, in B-cell lymphomas, we've shown that downstream of an antibody that sticks out of the B-cell lymphoma, if you look downstream at signaling molecules, that's where all the major therapeutics have evolved. And so we started looking at downstream of the T-cell receptor, which because it's a T-cell disorder. And at least one target is very exciting. It's called P38 gamma. It's in a signaling pathway that relates to proliferation through the T-cell receptor. And we have, through a screening of a library, a chemical library, we came up with drug that works very effectively. You had brought up the practical issue before about what do you do if you can't get intellectual property around a drug? Who wants to develop it? Nobody. So we've now, with colleagues at Northwestern, have wrapped it in a nanoparticle, and it's been picked up by a company, and we'll see where that goes. So that's what we're doing. And I want to, before I leave, I want to thank you again for everything you do for our patients and for all the physicians and nurses involved in the treatment of patients with cutaneous lymphomas, Susan.
Yeah, it's our pleasure, but I'm going to let Dr. Mangold have the last word.
I think one of the therapies that's in early phase human trials that everybody's probably heard a lot of buzz about, specifically in other systemic lymphomas, are the genetically engineered immune cells, CAR T cells. There are CAR T cell trials ongoing in skin lymphomas. They're in the first cohort of phase 1. The second cohort should be opening with some of those studies starting next year. And those are things, I think, Susan, getting to that point, when you look at the genetics of mycosis fungoides, there have been thousands and thousands of patients who've been sequenced with these diseases. There's not going to be a single home run. And what this opens up is the idea of creating that sort of concierge immune cell that can kill cancer for you. There are risks of them, and it's not made for everybody yet, but I think it's a pretty exciting therapy on the horizon. There have been very good responses described in the early phase human studies.
Good. That's a good note to leave on. So thank you both so much for joining us and for being willing to share your knowledge and wisdom and experience and perspectives. Whoosh, been a long day. Really appreciate it and look forward to seeing you along the way and keeping track of what's happening in your practices. And again, thank you so much for sharing your time on a Saturday afternoon with us and with the patients. So always a pleasure and an honor to have you with us. Thanks so much.
Thank you.
Take care. Bye-bye.
Take care. Have a great rest of your weekend.